We looked at PK/PD properties of antibiotics used for C. diff infection and identified risk factors for the development of new onset and recurrent C. diff infection. Now, let's assess clinical presentation and diagnostic laboratory findings to determine if a patient has CDI. Clinical presentation of CDI can range from asymptomatic in those who have immune response to the toxins producing antitoxin antibodies to patients who do not have immune response and develop diarrhea, and for some patients fever, abdominal pain, nausea and vomiting. And complications of CDI can include pseudomembranous colitis, toxic megacolon, shock, and of course death in severe cases. Diarrhea is the point where clinicians have to decide if it's due to CDI or due to other causes. Diarrhea can range in severity from minimal self-limited disease to profuse with 2 or more episodes per day. Now, about a quarter of patients can actually be expected to resolve the symptoms by simply stopping the offending antibiotics without using any specific C. diff infection treatment. Now, one significant finding in patients with C. diff infection includes leukocytosis. It is very common to have patients with C. diff infection present with white blood cells more than 25,000 cells per ml. And in fact, for some patients, in severe cases, white blood cell can exceed 100,000. In this picture, we can see what the toxin A and B can do to the colon, resulting in these lesions throughout basically the colon. And this is where the patients will have complications by forming pseudomembranous colitis. This is where the epithelial integrity will be disrupted throughout the colon, leading to these lesions. Now let's take a look at diagnosis of C. diff infections. The IDSA guideline recommends that patients with unexplained and new onset with at least 3 unformed stools in 24 hours are preferred target population for testing for C. diff infection. In other words, if someone only had 1 or 2 watery stools, they're not really a candidate for testing for C. diff infection. And by 2, I mean within 24 hours. It's important to avoid routinely testing stool from patients who have received a laxative within the previous 48 hours because laxative can lead to these frequent unformed stools, and that would be a more likely cause of watery stool as opposed to C. diff infection. Now, in general, the 3 commonly used tests include nucleic acid amplification test, or NAT. So this is basically a PCR based assay. We also have stool toxin enzyme immunoassay test. We also have glutamate dehydrogenase, or GDH test, which is considered a C. diff antigen. Now let's take a look at the differences between these. The nucleic acid amplification test is by far the most sensitive and specific test. The cost is significantly high, but is starting to go down compared to other tests that are available on the markets right now. Now, pretty much all of these tests are pretty rapid, so the results will be available quickly in the same day. The GDH test basically detects the highly conserved metabolic enzyme, which we call the common antigen, which is present in both toxigenic and non-toxigenic strains. So it basically tells you if the C. diff is there, it just doesn't tell you if it's toxigenic or non-toxigenic. Now it's important to know that this test is sensitive, but it's not specific. With the stool toxin enzyme immunoassay, this is the test that actually tells you if the toxin is present or not. So the GDH test and this toxin immunoassay, enzyme immunoassay, are actually used in combination. So together they will tell you if the C. diff organism is there, and then it will tell you if it's toxicogenic or not. Now, with the nucleic acid amplification test, because it's very sensitive, it's important to only test the sample from patients who actually have signs and symptoms of C. diff infection. Because if you were to do this on any stool sample, then you're going to identify all the colonizers. So it's very important to avoid over diagnosis of C. diff infection. So clinicians can improve laboratory test relevance by only testing patients likely to have C. diff disease. This includes not routinely performing tests on stool from a patient who has received a laxative within the previous 48 hours. Now, laboratories can also improve specificity by rejecting specimens that are not liquid or soft. Now, the IDSA guideline basically has two ways for diagnosis of C. diff infection. So for institutions that actually require clinical signs to be satisfied prior to submission of stool sample for testing, for those institutions, you can either do the nucleic acid amplification test alone, or you can use a multi-step algorithm. Now, in institutions that there is no agreement between the lab and clinicians to only test the sample from those with clinical signs, then a nucleic acid amplification test alone is not recommended. A multi-step algorithm is recommended. And here's what the multi-step algorithm looks like. So basically, once the stool sample comes into the lab, we will perform enzyme immunoassay for the GDH. So that will tell you if the C. diff organism is there or not. And then they will perform a enzyme immunoassay for the toxin A and B. And this will basically tell you if the strain is toxigenic or non-toxigenic. So if both of these happen to be positive, so if it's GDH positive and toxin positive, then the conclusion is that the patient has C. diff infection. And of course, on the other hand, if both of them test negative, then it's concluded that the patient does not have C. diff infection. Now, if there is discrepancy between these two, meaning that either GDH is positive and toxin is negative, or GDH is negative but toxin is positive, then it's recommended in this algorithm to do the nucleic acid amplification test just to confirm this discrepancy. So if you do the PCR, which basically pretty much the PCRs that are available, they look for the gene for the toxin B. And if the gene is there, then the conclusion is that the patient has C. diff infection. Whereas if the gene is not there, then the conclusion is that the patient does not have C. diff infection. Now, according to IDSA, do not repeat testing within 7 days during the same episode of diarrhea, and do not test stool from asymptomatic patients except for epidemiologic studies. However, for symptomatic patients with a high clinical suspicion of C. diff infection but a negative C. diff infection test, particularly those in whom symptoms worsen, a repeat testing should be considered. Now, given that recurrent C. diff infection occurs commonly, a recurrence of symptoms following successful treatment and diarrhea cessation should be assessed by repeat testing. Now, once somebody receives treatment for C. diff infection, there is no clinical value in repeat C. diff infection testing to establish cure, because more than 60% of patients may remain C. diff positive even after successful treatment.